This is part 2 of temporomandibular disorders and orofacial pain, where we'll continue with the clinical evaluation, specifically palpation. Then we'll talk about disc dislocation and arthritis. Let's now talk about muscle palpitation. So first, hopefully you appreciate that. You know the muscles of mastication by now. This is the masseter, right in front of the mandibular angle. Big dense muscle, you can feel it when you clench. And what are you doing when you feel it? Just feeling for fun? No, you're asking the patient if this is reproducing their symptoms or if it's causing any pain. Is it tender? Is it tight? And then B is showing what? And you want to really feel all along here, because remember the temporalis fans up here on the temporal portion of the skull. And so really see if there's any knots, see if there's any particularly tender spots. And then C is inside the mouth, so you do need to do some intraoral palpation. And he's palpating right against the coronoid process, and that's the temporalis tendon. Sometimes people are tender right there. And so if you can really localize their pain and their symptoms to one of these muscles, that's a slam dunk. Now, they used to do more where they try to palpate the medial and lateral pterygoids, but they found there's a lot of false positives with that. If you imagine putting your finger that far down someone's throat, they're going to be sensitive. They're not going to like it. And they may complain of pain even if that's not the cause of their symptoms. And so you can try that if you want, but I'm not going to show that in this slide. And then this is palpating where? Right over that joint. Palpate with one finger. So palpate them in the closed position and in the open position. You can kind of feel as they're opening, is there any click, any pop, any crepitus? Also, you want to take a range of motion measurement. In most adults, they should be up to about 5 millimeters or more. And so she looks like she's a little limited. Some of that may be smaller anatomy. Then you also measure lateral or excursive movement, and that should be around 10 millimeters on each side. And when you do this opening, you actually do two different things. You ask them once to open how far they can open without pain, and that may be limited. And then ask them, okay, open as far as you can, even with the pain. And if they're able to open even more, if you can kind of stretch them out and get them to open more, that's more of a muscular issue. If there's a hard lock, though, you're dealing with something more intracapsular. And we will briefly mention this because it does matter, and a lot of times this gets skipped. As I mentioned before, a lot of times there's a psychological component when someone has chronic pain. Chronic pain syndrome is when they've had pain for a long time, and that leads to exaggeration of their symptoms. And there is comorbidity of psychiatric illness in TMD patients, as high as 10 to 20%. So 1 out of 3 suffer depression, 2 of 3 have had severe depression episode in the past. Also a thing to consider, psychiatric disorders may elicit parafunctional habits. Chronic pain, of course, can lead to anxiety. And so any questionnaire you have, it should have questions about this regarding functional limitations. That might reveal some behavioral changes. And from that, you need to determine, is further psychological evaluation warranted? You might need to just ask them straight out, do you think you would benefit from evaluation from a psychological professional? And use your judgment and refer if needed. And so if you're looking for a questionnaire out there, there's a lot of different ones you can get. At the University of Washington, they had a 14-page questionnaire that they'd have patients go through, and they'd analyze that, and then they compare their answers at time intervals to see, hopefully they're improving by whatever treatment you decide is appropriate for them. While we're on that topic, a little thought question for you. You know, you can't lose a homing pigeon. If your homing pigeon is lost, then what you've actually lost is just a pigeon. All right, now we're getting into diagnosis. So back to the list that we mentioned at first, we got our somatic conditions, myofascial pain, disc derangement, arthritis, infection, tumors, and then our neuropathic conditions, our neuralgia and headaches. First of all, myofascial pain, the most common cause of TMD. And this is resulting from just abnormal function hyperactivity of the muscles. The picture is just diffuse, poorly localized pain in the muscles of mastication. And so we said do those palpations in the last video, right? This is the type where you're palpating, and some of the muscles of mastication are typically more tender, whereas palpation right over the joint is not tender. May be associated a lot of times with clenching or nocturnal bruxism. And it is multifactorial. Stress, anxiety can lead to it, as well as if they have occlusion that's not correct. This may be secondary to disc derangement or arthritis. This could lead to bitemporal headaches, trigger points. And so really what you need to know is this is associated with a muscle, and their opening may be limited, but it's due more to muscle pain, muscle tightness, than it is to an actual lock, an actual physical thing inside the joint. All right, then what is disc displacement? We said in health, the disc should stay adhered to the mandibular condyle. But in some cases, that disc slips. It moves around over time, over use, and it can become out of place. Most commonly, it's going to be displaced anteriorly, sometimes anteromedially, or medially, or laterally. And so what happens in this disease? Well, early on, there may be mild displacement. There might be a pop or a click on opening, and it's asymptomatic. As it gets to more the intermediate stage, it starts creating symptoms. That's where you have multiple episodes of tenderness, can lead to headaches, intermittent catching or locking of the disc. The disc is starting to deform, and in some cases, it's not popping into place. We'll show you about that pop in a second here. And then the late stage is when you have crepitus and grinding, and that's more your signs of osteoarthritis, variable and episodic pain, restriction of motion, difficulty with functions. So it's just getting worse and worse. And now you're really degenerating the disc. You're getting to the point where it's locked out of place. And this is what we mean by that. In this first image, it's showing the disc adhering to the joint as it opens, even as it translates. In the second image, it's anteriorly displaced. But then as the patient starts opening, remember the first part of opening, the first 20 millimeters, is just rotation. So it can rotate. And then as it starts to translate, it pops over that retrodiscal tissue. That's what you're seeing here. On closed, the disc is anteriorly displaced, but as they open, it's popping over that retrodiscal tissue and it's reducing back into place. We call that disc displacement with reduction, or DDWR. And so a lot of people don't understand this. They think the disc is in the normal location when the patient's closed, but it's actually going back to the normal location only when they open. And so that's kind of our early stage, and then maybe our early to intermediate. And then when it gets to the late stage, that's when it's locking out of place and it's staying out of place. So severely displaced. And now we're to the point where the disc is so far displaced here and those retrodiscal tissues are stretched out so much that no matter how much the patient opens, they're not able to get that disc to reduce again, to pop back there. And so instead of doing that, it just pushes more forward and it starts to deform. It can start to erode. Here's a nice video if you want to click on that and watch how these different forms of displacement look. And so this is just to answer the question, why is it that the disc tends to displace anteriorly or anteromedially? And that's because of this right here. We have the lateral pterygoid. This is our medial pterygoid. You can remember that because it's just opposite the masseter. They both start with M. But the lateral pterygoid is more lateral, of course, and it attaches to the condylar head, but there are also some fibers that attach to the disc, if you saw that in the anatomy. And so the pull from this kind of constantly pulls that disc forward. And over time, that disc gets pulled forward out of place, sometimes medially displaced. That's usually what leads to it. All right, you're not going to see many MRIs, but just to show you how you can see the disc, it has a bow tie appearance, meaning on the anterior and in the posterior bands, they're thicker. So this is a sagittal slice. If you've never looked at an MRI before, you probably have no idea what I'm pointing at, but maybe you can appreciate that looks like the shape of the condyle. As far as bone, just think opposite of what it looks like in a radiograph. In this case, it's darker on the outside and it's brighter in the middle because there's marrow inside the bone. But you can see soft tissues really well. See how you can see the fibers of this disc and that posterior displaced. Usually that posterior band is at 11 or 12 o'clock position. And the intermediate part, which is the thin part of the band, sits between this anterior superior surface of the condyle and the posterior surface of the articular eminence. And so this is the patient closed in health. And then this just shows a coronal view, how it's not displaced laterally or medially, either direction. And this shows a disc that's severely displaced. These various images show discs in different locations and different stages of being squished and curved. This one, you can also appreciate some of the bony changes as well. But really good for looking at discs. What do we see here? This arrow is pointing to the posterior band of the disc. These are just some of the fibrous connective tissues. And so this is closed, the disc is out of place. It's anteriorly displaced. When the patient's opened, well, what happens? The disc pops back into place. So what did we call that? That's disc dislocation with reduction. And you can mostly diagnose this clinically when you have that pop, either with or without symptoms. At a certain point of when they're opening, you can tell when it's popping back into place. But if you really want to see the disc, nothing is going to do that other than MRI. All right, give you a second to diagnose this guy right here. I come to your office and I say, I got some pain in this joint here. And you start digging, you do the questionnaire. Well, the pain's more common when I'm chewing, when I chew a lot of gum, probably from overuse, right? And I say, well, I've also got this pop here, and I think it needs to be fixed. And so what's going on with me? Here, listen. Once I open to a certain point, beyond that, you hear the pop. And you ask me, is it painful? Well, no, in most cases it isn't. It is when I have those instances of feeling like I've overused it, I've chewed too much gum, and it's painful. Sometimes it hurts me a lot when I'm running. I think I probably clench my jaw. And so is this someone that's going to need some treatment? Well, what's going on, first of all? Can you recognize that I probably have anterior disc dislocation? And when I'm opening, that single pop and click, what you hear is the reduction. So remember, disc dislocated anteriorly, and then as I open, as I start to translate, pop, that's the disc popping back into place over the condyle. And so I have disc dislocation with reduction, and I've had that for probably a couple decades at this point. But for the most part, it hasn't bothered me. And we'll get more to treatment at the end. But if someone's asymptomatic, in most cases, it's not going to be treatment. If I had more symptoms in the morning, when you thought more it was maybe related to nocturnal bruxism, I could get a night guard, but not really the case for me. All right, now let's cover some arthritis. The big one, osteoarthritis, and then the second one to know would be rheumatoid arthritis. A little bit about these more rare ones. So degenerative joint disease is our term for osteoarthritis. That's a breaking down of the articulating fibrocartilage. It leads to deterioration eventually of the bony structures. So it is considered non-inflammatory. You'll see erosion as well as bone formation. What I always talk about is this is considered non-inflammatory, but you can think of it as a low-grade inflammation because you have the same signs of some bone resorption, some bone formation, so similar to being acute versus chronic. The incidence increases with age. Of course, we'll see this across both genders, maybe a little more common in females. And in some cases, this will be asymptomatic. Where you're going to see this is typically in the condyle or the articular eminence. And what part of the condyle do you think? In any joint, it's going to be against the articular surface. And so you have to have the condyle is that part that sits against the articular fossa where you typically start to see changes. And we'll talk about these different signs, but one of the signs you look for is that erosion that I showed you in that previous CBCT. So these are the 5 signs. Flattening, I have a question mark. If you just have kind of normal broad condyle, that might just be physiological. It might just be anatomical or physiological changes to it rather than a sure sign of joint disease if they don't have any sclerosis, any erosion, any of these other things. But reduced joint space is one. Remember, the temporomandibular joints should have that disc in place. So there should be a little bit of a gap between the mandibular condyle and the articular eminence. If you start to lose that gap, that means the disc is out of place, which is one of the first signs of arthritis. Sclerosis, hopefully you remember what that means, just dense bone. That's what's being drawn here in this cartoon. Osteophyte formation or bone spur is the colloquial term for it. Subchondral cyst is when you have an erosion that then has covered up by bone. So it's a small round radiolucency or hypodensity just beneath the joint surface. And then an erosion is when it's actually eroding from the joint surface. So what do we see here? A little bit of thickening in that cortex. That's a little bit of sclerosis. A little more flattening here. What about this kind of beaking here, that sharpened anterior portion? That's an osteophyte. Here's a cadaver specimen showing those changes. Some round, what would be lucencies in there, probably subchondral cysts. Let's just go quickly through a few more examples. Flattening, loss of joint space, sclerosis, some erosions on the surface here. Both of these show osteophyte formation. The round hypodensity just deep to the joint surface is a subchondral, or also called an Eli cyst. These are all just signs of osteoarthritis. This case is a good one. I think this is the same one I showed you before with some erosions. You can see in the coronal slices. Here you can see it in the cross-sectional slice. This one also shows, what do we call this, beaking? That's an osteophyte. Some flattening, maybe a little sclerosis throughout the condylar heads, just along the articular surfaces. And in some cases, you may see a lot of sclerosis all throughout the condylar heads. And then occasionally these osteophytes are going to get loose and fracture from the joint, and they remain as loose bodies within the synovial cavity. It's not super common, but as far as calcifications within the joint space, it's probably the most common one. And so here's a sagittal reconstructed image from a CBCT showing these, it looks like fractured off little pieces of bone. And what you really want to look for to distinguish this from other causes of calcification is, do they have those signs of degenerative joint disease? Are there signs of arthritis here? Yeah, there's sclerosis. There's an osteophyte here. So it's easy to surmise that that's probably just a fractured off joint mouse, just a fractured off osteophyte. They typically occur around where you see osteophytes, and that is typically in the anterior joint space. Maybe in some cases you'll see it on other sides, but when I started seeing it all around the joint, I think of something else, synovial chondromatosis, which we're going to talk about more in the skeletal muscular lecture. And then we're going to talk about inflammatory arthritis, because that can appear just the same. It tends to be a little more erosive, although it can appear really similar to degenerative joint disease. Benign tumor, osteoma or osteochondroma. Toward the end of this, I'll show you an example of that. But we do need to talk about rheumatoid arthritis. And This is an autoimmune disease, and this is where autoimmune disorder causes destruction of joint. And this has to do with inflammation. So this is more active inflammation. It progresses more rapidly. Its onset is earlier. It tends to affect the peripheral joints before it affects the TMJs, but in about half the patients, it will affect the TMJs. And this is quite a bit more common in females, 3-to-1. And it increases in age. But what I just said is that the onset tends to be a little bit earlier compared with degenerative joint disease. So yeah, it can happen more and more as patients age. But if you see an earlier onset version of this, a 30-year-old or a 40-year-old with really erosive disease, think rheumatoid arthritis rather than degenerative joint disease. And so we talk about it being very erosive, but a lot of these cases, you'll see a lot of sclerosis as well. And the reason for that is it kind of accelerates degenerative joint disease. And so you'll see subchondral cysts, you'll see osteophyte, you'll see sclerosis, just like these other things, even though rheumatoid is known as being more inflammatory and more erosive. And this can be so severe in some cases that it leads to ankylosis, whether fibrous or osseous ankylosis, and we'll show you that in a minute here. One of the classic signs is the outward bowing or the ulnar drift of the fingers toward the ulnar bone. Maybe hard to appreciate that here. We're not used to looking at hand radiographs, but there is some osteopenia against the joint surfaces in the hand. Like I said, it typically starts in these peripheral joints first. And then what are we looking at here? Lateral cephalometric. All that really stands out is it looks like the condyle is missing, and it's bilateral because it's not perfectly symmetric, but it's happening at roughly the same rate with both of the condyles. And that's fulcruming on the molar teeth, which is causing an anterior opening. And so all I can really say from this is there's something severely destroying both condyles. Could be a very severe form of arthritis. And then looking at this tomogram, they used to do a lot more of these tomograms of the TMJs, you can see this kind of sharpened pencil appearance, where the condyle is worn down from the articular surface and left this kind of pointed pencil appearance. And that's classic for rheumatoid arthritis. I suppose it could happen in some of these other diseases where you have severe arthritis, but that's one of the known presentations of rheumatoid arthritis. And so basically it can look like just a severe, maybe a very erosive, very destructive degenerative joint disease. Think also a potential psoriatic arthritis, which is another autoimmune disease that can affect the joints. And there's a handful of autoimmune diseases that can cause arthritis inside the temporomandibular joints. Probably won't go through all of them. And so the takeaway is this: you see severe erosions, involvement of other joints. That could indicate rheumatoid arthritis. That patient is going to require medical workup. Here's another deep thought for you. Maybe you can share this with your TMD patients. I'm sure they'd really appreciate it. All right, the next one I wanted to talk about is juvenile arthrosis, or most books refer to it as idiopathic condylar resorption, also known as cheerleader syndrome. So if the cheerleader looks familiar here from our AOC, from the well-defined hypodense lesions with calcifications, that's because this is part of the same demographic, but now it's something that affects the TMJs. And so you can think of this as just a really quickly progressing degenerative disease that occurs in a patient population you wouldn't expect. Typically teenage females. And these two images, if you look at the third molar developing, these occurred about 6 years apart. And notice the toadstool flattening of the head of the condyle here. That's kind of the classic appearance for this, right? You wouldn't expect a teenage girl to have this degree of arthritis, but everything else can look just the same as arthritis. There are thoughts to whether this could be a form of avascular necrosis. They may or may not have symptoms. Just like with any severe arthritis, when you've lost condylar head height, they may develop an open bite. And so nothing super specific about the imaging here, but it's really the patient population and the fact that it's just very advanced degenerative disease. But if you see that toadstool appearance, that is kind of the classic sign. Of course, you've also got to consider whether it's just juvenile idiopathic osteosclerosis. Typically happens younger, and that can happen in males or females. Or if they're a little older, maybe it is just a form of severe degenerative joint disease. And this is pretty severe, so in a lot of cases, it will require surgery to correct. And that leads us to the next one, which is juvenile idiopathic arthritis, which you can think of this as just the pediatric version of rheumatoid arthritis. In fact, it used to be called juvenile rheumatoid arthritis, but they discovered that it's not necessarily associated with the rheumatoid factor. And so this presents before the age of 16. You can see the average here is 5. This is a little more common in females, but unlike the last one, it's more of an even split. This may produce pain. It may be unilateral. One of the common clinical presentations is a bird face, the anterior open bite, kind of the deficient mandible, Remember, these kids this age, the jaw is still developing. And so if they have this severe arthritis of the mandible, the jaw's not going to develop and not going to come forward as much as it should. And that's what causes them to develop this bird face appearance. And so again, this can just appear to be an aggressive osteoarthritis, but it's the demographics that it affects children. It tends to be very erosive, so a little bit more like rheumatoid arthritis in that regard. But again, similar to rheumatoid arthritis, although it tends to be erosive, it may have those sclerotic changes as well. It kind of accelerates degenerative changes, as we see here, this last point. All right, and then septic arthritis, that implies infection. So you could also call this inflammatory arthritis or infectious arthritis, just infection and inflammation that settle in a joint, and in our case, the TMJ. It can result in destruction. It is somewhat rare. It can spread from some infection nearby, and then in rare cases, just hematogenous spread from a distant site. This can occur in any age. It can cause severe pain. Imagine having, active inflammation just right inside that joint. It's going to be tough to open, tough to chew, tough to bite. Because it's infectious, it could be associated with lymphadenopathy, malaise, fever. And so this is an interesting one here. The mandibular deviates toward the unaffected side. That's different than how we most talk about it. And the reason for this is really it's talking about at rest. Say you have infectious arthritis in the right joint, there's going to be so much swelling and effusion inside that joint space that it kind of pushes the mandible downward, and that creates a leftward deviation. So it deviates toward the unaffected side. If they were asked to open all the way, they'd probably have decreased range of motion toward the right side, and just like with most diseases, then as they open, it would deviate toward the affected side. And that's what this is talking about here. Joint space is increased due to inflammatory exudate. And so they have a lot of fluid or effusion inside the joint space. And so this can create erosions, even sequester in some cases. And then here's the big thing to look for. Remember Shrek, looking for signs of infection. If you see periosteal bone formation and they've got signs of arthritis, pain, especially heat and swelling, then you're thinking some degree of osteomyelitis and infectious arthritis. But other than those specific changes, it can look just like degenerative disease, rheumatoid arthritis, these similar things we've talked about. So here's our case here. If we look in the sagittal view here in image B, it looks like an erosion, looks just like an aggressive osteoarthritis. But then what's the arrow indicating? This parallel periosteal reaction, this onion skin reaction. And so you remember Shrek, and he's telling you that there's infection going on in this joint.